Well, welcome everybody to the spring showcase of our various conferences, whether it's SCI or ACC or the Heart Rhythm Society. So we have a mighty group here this morning. So we're going to go through each presentation. We will take a quick Q&A between, and then if there's any holdover at the end, we can certainly pick those up. So I'm not going to make your introduction long. Dr. Travers, he just got in from Italy with a little jet lag and a cold, but he is here, and I know that he's going to do a great job. I do want to thank AstraZeneca as our sponsor today. Sean's here, so all right. Well, let's get on with it.
All right.
Thank you.
All right, look how busy that is. Okay, you can't even probably read it. So I'll just go through it. So this study is being presented from one of our summer intern students, Marissa Doulis, a Saturday at ACC, and its title is Cardiovascular Complications of COVID-19 and Its True Mortality in a Large Metropolitan Health System. So what's different about our study? Well, so first of all, if you go on PubMed, there's 242,000 studies on COVID already in the literature, and there's 24,000 on COVID mortality and 12,000 on COVID and cardiovascular disease. So it's like a high bar. What can we do? Well, I think we did do a little bit different. First of all, this study is just comprising all the deaths in the first year of COVID in all the Allina hospitals. So this is just patients that died. And it's an individual chart review as opposed to almost every other study out there. They use algorithms and computer databases, or they use Medicare for the deaths. So there's no nuance to, why did people die? I mean, I think it was somewhat of a controversy, that patients did you die from COVID or did you die with COVID? And I think that's an important distinction. And we know that, very early on in this disease, when those reports from Wuhan came out that showed that if you had an elevated troponin, that your mortality was markedly higher. If you had cardiovascular risk factors like diabetes, hypertension, obesity, then your risk of mortality was much higher. So clearly there was, with the troponin, the heart, there's something going on. So we decided to just focus on the people that died. And so we started in March of 2020. That was when the first Allina Health COVID patient was, and we continued it to December 31st of that year. And this is so small that I can't even see the numbers here on this screen. But we started out with about 500, 455 patients. So we got a list of all the patients that died with COVID, either from it or with it, from Allina. I think Craig Strauss was really helpful in getting us those names and numbers. And Marissa Doulis then went through every single chart, and then we adjudicated all the deaths, both myself, another physician, usually it was the hospitalist that was taking care of the patient, and this was comprised of both Abbott, Mercy Unity, and United. So these are from all the metropolitan health systems. So just to go through this here. So there's 455 patients. There are 371 patients that we determined that died from COVID, and 84 patients had COVID but died of other causes. So how did we determine? Well, we said that they were classified as dying from COVID if they had a positive COVID test and a chest x-ray consistent with COVID-19 and suffered from progressive respiratory failure, or ARDS. So that was 371 patients. But patients who had incidental finding of a positive COVID test whose respiratory status had recovered and died from other causes were classified as non-COVID deaths, and that was 84 patients. So if you start here in table 1, oh, that's cute. It enlarges up there too. All right, so let's start right up there. So there are about 40% women in both groups. So we want to differentiate where there, besides the risk factors overall, were there differences between those who died from COVID and those who died with COVID. So you can see the BMI here was enhanced, and there was a significant difference between the COVID deaths and the non-COVID deaths. People that died from COVID had significantly higher BMI and trended towards, obviously more obesity. Age was similar. Race was similar between the two, as was ethnicity. So that's kind of the patient population. Okay, so let's go over to table 2 here. Now here are all the risk factors. Maybe I can't, let's see, we'll try. Here are some of the, let's see if I can expand this. Okay, can you see that, sort of? Okay. So again, so let's look at the cardiovascular risk factors. Hypertension, history of smoking, even though it was 0.06. So I mean, that was a trend towards if you were a smoker, then you were more likely to die from COVID as opposed to with COVID. No difference in dyslipidemia or history of coronary disease. Diabetes was slightly more, but not statistically significant in those who died from COVID. COPD, again, you know, if you had more patients, that would be statistically significant, but it also favored those people who died from COVID. Chronic kidney disease or dialysis, no difference between the two groups. Pulmonary hypertension, no difference. History of PAD, history of MI, history of CABG, and history of PCI were all similar between those who died from COVID and with COVID. And I think part of that is because the people that died from other causes, most of those died from cardiovascular causes, which may have helped even that out. Same thing with stroke, valve disease, valve replacement, history of AFib and flutter. So that's interesting. We'll come back to that because history of atrial fibrillation is a very strong risk factor for mortality in this disease, especially if it's new AFib as opposed to chronic AFib. And then history of obstructive sleep apnea was significantly higher in those patients who died from COVID as opposed to with. So you're sort of seeing a trend. You're seeing how the lungs are involved in this, which, I mean, I guess that's not rocket science, right? But, you know, you're seeing that they were smokers, they trended to have COPD, and they definitely had more sleep apnea, they were more obese. So all those sort of things that would, you know, make them more susceptible to respiratory disease. Now here's the in-hospital comparisons between the patients. Length of stay was longer with COVID, as to be expected. Acute kidney injury, no difference. An MI in the hospital was actually a little bit, I mean, it wasn't significant, but it trended in the non-COVID group again because a lot of the patients that died with COVID as opposed to from COVID had myocardial infarctions or cardiovascular disease. PCI was significantly higher in those who died with COVID because they had MIs and underwent primary PCI. Shock was no difference, except cardiogenic shock was higher, 7% versus 2%, again reflecting the cardiovascular issues in people that died with COVID. No difference in septic shock or other types. ECMO was surprisingly not a lot of cases with ECMO in these patients that died. I mean, it was very interesting when you looked, we didn't have this on here, but when you go through all these charts, which I did, the amount of people that had dementia was unbelievable. It was off the charts. And so I think a lot of those patients, there's no way the family was going to let them go on you know, an ECMO. So I think that's why, in part, so the numbers are so low. And then as far as atrial fibrillation or flutter, significantly higher in those patients that died from COVID. So in the hospital, so 41% versus 29%. And that, I think there's been other studies now that have showed that AFib, especially if it's new AFib, is a big risk factor for mortality in COVID. Okay, now let's see if, I don't know if I can move this. We may be at the end of the road here as far as, let's see. Well, all right, now how about troponin values? This was a thing that got everyone's attention from Wuhan way back. In fact, we actually wrote a protocol and got it approved by the FDA to use cell therapy for patients that that had elevated troponin because the risks for them were so high. But unfortunately, you could never get funding, even a meeting with DARPA and everything. Because and you know, in retrospect, I don't know that it would have done anything anyways. But troponin was a big risk factor, and you can see that here that oh, there we go. The median troponin was 0.06. COVID versus non-COVID was actually higher in the patients with the COVID deaths, although not significant. BNP, not significant, slightly elevated. Creatinine, again, was elevated, but not significant. And then table 5 just shows some of the therapies for this. So Obviously, a lot of people that incidentally had COVID but had other things, they were throwing the kitchen sink at them, so they threw, dexamethasone and any, convalescent plasma and antiviral therapies, even though that wasn't their primary cause of death. But you can see, not surprising, that they had higher antiviral agents in dexamethasone in those that died from COVID. There's the infamous hydroxychloroquine initially. 4% of the COVID deaths got that. A higher amount of monoclonal antibodies. BiPAP and CPAP was much, much higher. Supplemental oxygen, again, reflecting the, the respiratory issues. And then days on the ventilator, definitely trended towards, obviously, the people that died from COVID. So, and then finally, if you look down here, so that we said there were 84 patients that we believed had COVID but died of other causes. And this is just this table there on the right, table 1 or figure 1, just shows the number of deaths broken down. And you can see, by and large, cardiovascular was the main thing. There's a few strokes, some septic shock, some cancers, and then what's that, dementia on the bottom? It's so small I can't even read it up here. And then other. So what did we learn from doing this? Well, I think what we learned, so that as far as I know, there's no reports out there that have gone through all these death charts and have a conclusion of how many people died with COVID versus from COVID. And also, I think, our findings aren't revolutionary at all in the sense, but they're consistent with what have been found by others that have been trolling, large databases. But I think there's a lot of benefit to actually doing individual patient data as far as, looking for nuance differences between the two. And so I think this summer what we're going to do is we'll start a new project, and now we're going to compare 2021 versus 2020 and look at the deaths again and see, so what's different? I'm sure there's been a lot of thinning of the herd, so to speak, from the first year of all the people that died. So are these people now going to be younger? Are we going to have less deaths? Are they going to have different characteristics? There's different therapies. We've learned how to treat COVID better. So it'll just be, and we're talking about the new, we're talking about Omicron versus Alpha and Delta. So there's going to be different viruses. Do they have different effects? So that'll be, hopefully a year from now, we'll be able to bring you that data. So I'll just stop now, and if any questions.
Just one thing you might want to mention, that the good thing about the data set is there's no vaccination. To use that as a comparator,
Yep.
then you can think about the next.
Perfect, yeah, good idea. All right, thanks a lot.
Okay, so we're going to have Dr. Bank join me in a minute. And Dr. Bank, across the river, where do you live, though? You may not live in St. Paul.
I live in Minneapolis.
All right, very good, excellent. So Dr. Bank is the medical director of research at MHI East at United Hospital and runs the core research lab there. He's been a PI in over 100 clinical trials and has published over 100 papers. His current research is focused on cardiac resynchronization therapy. His research lab has developed a novel therapy for technology for measuring electrical dyssynchrony, and he has submitted 5 patents on this technology. He's currently leading research studies using the technology to optimize programming in CRT patients. So we really welcome him today to talk about the Heart Rhythm Society.
Thanks very much. So today I'm going to talk about cardiac resynchronization therapy optimization in non-responders using this technology we've developed called electrical dyssynchrony mapping. Those are my disclosures. So the background. Non-responders are a major problem with cardiac resynchronization therapy. About 30% of patients who get CRT are non-responders, and there's a lot of different definitions of non-response. Some people base it on clinically not improving, others on their echocardiographic measures. EF doesn't improve more than 5% or so forth. But you see this spectrum on the left there. There's people who actually get worse with CRT, and there's probably 15, 20% who continue on this downward course of heart failure, and then some that just kind of stabilize out and don't improve but don't worsen. What's important about this is that these non-responders have a very poor prognosis compared to patients who respond. Their increase in heart failure events is 6-fold over 2 years. The cost of care of these patients is 10-fold over that 2-year period. So this is a group of patients that's very high risk for problems. And just to give you an idea, there's about 160,000 CRT devices placed annually in the United States, and there's over 1 million patients, who have these CRT devices in place. And if we can figure out how to take this therapy and optimize these patients, it could have a big impact. In addition, there's no well-accepted, proven approach to treating non-responders. A large study recently published showed that 44% of non-responders receive no treatment. So these are patients that have a high mortality, a mortality like a cancer patient, and yet they get no treatment. And when I say no treatment, I mean they just get basic heart failure care. They don't see, a lot of them don't see a heart failure specialist. They don't get their devices interrogated in order to figure out if you can reprogram them or other strategies. So our methodology involves the concept of wavefront fusion. So with CRT, there's 3 wavefronts. There's the native wavefront that comes from the atrium down through the AV node. And then there's the RV paced wavefront, which is in blue here from the RV lead, and the LV paced wavefront. And the goal is to improve the intra-LV dyssynchrony by having these 3 wavefronts fuse, and you want them to meet in the middle of the LV. If the wavefronts meet in the middle of the LV, then that means there's been the shortest amount of activation time to get the myocardium depolarized. And you can see on this view here that the RV lead is sitting over here in the septum, LV lead in the posterolateral LV, and then V1 is pretty much parallel to where these wavefronts are going to be moving. So this is the technology we developed. We put 9 electrodes on the front of the chest and 9 on the back of the chest. This is just from standard EKG machines. We just wheel in one EKG machine, put it on the front, another EKG machine, put it on the back, and we just collect the electrograms. Then we take these 18 electrograms and we superimpose them on top of each other. So here's the patient's native, and there's the 9 blue electrodes are moving away from the chest, the anterior chest, and the 9 posterior electrodes moving, the wavefronts moving towards them. What we do then is we can calculate with our algorithm this space between these curves. So there's 9 times 9 is 81 different pairs of spaces between all these curves, and the gray area shows you the net area under the curve, or the net area between the curves. And what happens is as these wavefronts fuse, the electrical activity gets canceled, because if you imagine, say, V1 sitting there, sees one wavefront moving towards it from the LV lead, one wavefront moving away from it from the RV lead, and those waves cancel each other, just like waves on a beach. If there's one moving into the surf, moving into the sand, and one moving away, and if they're timed right, they cancel each other. So what you want to see is crunch, squish, and flip. The electrograms get crunched and they get squished in amplitude, and then as you get further along and you get too much LV preactivation, they flip. So we can do this, and we can generate a thing called cardiac resynchronization index, which is basically the percent change in this area under the curve. So this is my electrograms. Area is -13, pretty small. There's a lot of wavefront cancellation. Here's a patient with LBBB. Here's a patient when they're optimally synchronized at the right setting. Everything's crunched and squished, and a small area. So we can then take these a patient and program at all sorts of different AV delays and VV delays, and this is a combination of different timings of the atrial sense to RV interval and the atrial sense to LV paced interval. And if we do this in 20 millisecond steps, we get this whole grid of, say, an 8x8 grid, 64 different measurements. And we can calculate the CRI at each setting, and we generate a map. And this is our electrical dyssynchrony map. And everything in the red is 80% resynchronized or better. Everything in the blue is 30% or less resynchronized. And we draw this optimal synchrony line, which is right through the middle of the red area. So if you program a patient anywhere along this line, they will be optimally electrically synchronized. And this line is just telling you a combination of a RV paced and a LV paced. So it's just telling you kind of what AV delay and what VV delay you want for your programming. So our study was to look at non-responders to CRT. We defined those as patients whose EF didn't improve by 5% or more. And then also look at incomplete responders, which we defined as patients whose EF didn't get to above 40%. And these patients were studied at least 3 months after CRT, and many of them years after CRT. We did an echo, we mapped them, we programmed their optimal setting, and then we repeated an echo at 6 months. So these were typical heart failure patients, age 70 years, EF about 31%. And here's what happened. So 31 of them were programmed with BIV pacing, RV and LV both leads firing. 11 were programmed LV only pacing. So in those patients, they were fusing the LV paced wavefront with their native wavefront. And we made all sorts of different changes. I won't go into these, but a bunch of different changes in the groups to get them to the optimal setting. Here's an example of a patient. So here's where the patient was programmed here with about, maybe 50, 60% resynchronization. We moved them over to here. And here's their echo. You can see on the top left, global LV hypokinesis, EF about 25%. And if you look on the right, the left ventricle is smaller, all the walls are coming in, and EF is probably 45, 50%. Here's what our overall results were. Pre-optimization to post-optimization, their ejection fraction went up 4.5%, which was highly significant. Their end systolic volume dropped about 10 milliliters, which was significant, and their end diastolic volume was also reduced, but not quite significant. Here's what happened to LV strain. So with echo, we can measure strain where we basically look at, it's an echo measure of contractility. We can look at speckles in the myocardium and see if they're moving closer together or further apart. And in these patients, the transverse strain went up, highly significant. Longitudinal strain went up significantly. Radial and circumferential strain went in the right direction, but not quite significant. We looked at interventricular mechanical dyssynchrony. So this is the timing of the beginning of the QRS to when the aortic flow starts compared to the timing when the pulmonic valve starts. So this is kind of dyssynchrony between the RV and the LV, and there was a significant improvement in that. Now this looks at patients before their CRT was placed. We started all patients at 0. This is a percent. This is a change in their EF. And then with CRT, these patients on average improved by about 4%. And CRI was about 50%. So they were 50% resynchronized at the standard settings. And by getting them to about 90 to 95% resynchronized, we were able to double their EF response. So it shows there's a pretty linear relationship between the improvement in electrical dyssynchrony and the improvement in ejection fraction. So if you look at this, what is the potential clinical benefit? Well, it's been shown in large studies like MADE-IT CRT that for every 5% increase in EF, there's a 40% improvement in outcomes, outcomes being reduction in heart failure event or death. So if you do the math and you use this technology and you get a 5% increase in EF on average, you can reduce heart failure events by about 8,000 in the United States every year. And this would be continually each year. So, summary, CRT non-responders and incomplete responders are 48% resynchronized at baseline settings. They can be optimized using this technology to about 91% resynchronization. We can improve LV systolic function, LV size, and dyssynchrony. And this is a non-invasive, practical, comprehensive methodology. There's no risk to the patient. You don't need any dye. You don't need any imaging studies. All you need is to put an electrocardiograms on a patient, use the algorithm, reprogram them. We can do this in about an hour, and we'll be able to do it in a half hour once we get better, faster algorithms and technology. And we think this could have a major beneficial effect on clinical outcomes in patients with heart failure. Thank you.
That's terrific. Is there something about, have you looked into the people that even after optimization don't get better? Is there something about those people that you'd be able to predict ahead of time so you wouldn't put the device?
Yeah, some of the patients that, there's a couple things. A few of them maybe didn't need CRT in the first place, so we're working on using our methodology to figure out who should get it and who shouldn't, because we can quantify their dyssynchrony before we put it in. But that's not very many. The more important reason is that their LV lead is in a bad location. And we can use...
Scar tissue or something? Or
I'm sorry?
Like in scar tissue or something?
Well, no, not so much scar... I mean, that may be a small issue, but I think more importantly, geometrically, it's not in a good position. If it's in the apex, it's no good because you don't get the wavefront fusion. Also, if it's too far anterior, because to get resynchronization, you have to have wavefronts that are opposing each other. If you have a wavefront here and a wavefront here, they're both going in the same direction, and you don't get any cancellation of the wavefronts, and you don't shorten the activation time very much. So we're working on looking at lead position in all these patients and quantifying it. I eventually want to work with John on using CT to figure out how to do that, and then we can see on the maps you don't get that beautiful red line there in patients where the lead's in the wrong place. Sometimes it'll never get to 80% resynchronized, or I had a patient where the whole map was blue because the lead was sitting way anterior and there was no cancellation of wavefronts at all. We took the lead out, put a new one in, and we got a beautiful map. So.
Great, thanks.
Thank you.
Awesome.
So another member of the Center for Coronary Artery Disease is Spyros Kostantinis. And Spyros, you have your 1-year anniversary with MHIF coming up, so that's exciting. So he obtained his MD from the National and Kapodistrian University of Athens in 2019, and then he was a rural physician in his hometown. And then we were able to get him. So he's been an active researcher since he's been here and is also interested in clinical training in the United States. So welcome.
Good morning, everyone. Thank you, John, for the introduction, and thank you very much for the opportunity to present today at Grand Rounds on behalf of the PROGRESS-CTO investigators. Our work that will be presented at ACC this year entitled Evaluation of the Open Clean CTO PCI Perforation Score in the PROGRESS-CTO Registry. I have no financial disclosures. Coronary artery perforation is one of the most feared complications of CTO PCI, as it can lead to pericardial infusion and tamponade. In 2021, Hirai and the Open CTO investigators published at Catheterization and Cardiovascular Intervention Journal an article about a score predicting the risk of coronary artery perforation during CTO PCI. The Open Clean CTO perforation score is computed from 5 parameters: prior Cabot surgery, occlusion length, ejection fraction, age of the patient, and severe calcification in the lesion. The score ranges from 0 to 7, and as we can see here in the figure of the original manuscript, the higher score associated with a higher risk of perforation. In the table, we can see how the points are assigned to each variable. Our goal was to evaluate the performance of the Open Clean score in the prospective global registry for the study of chronic total occlusion intervention, or PROGRESS-CTO registry. PROGRESS-CTO currently includes more than 10,000 procedures from 63 participating centers from 9 countries worldwide. And Minneapolis Heart Tissue Foundation, MHIF, is the coordinating center. For this project, we used complete data of 6,422 patients who underwent the procedure between 2012 and 2021, and we calculated the score for each individual patient. Here are some details about the statistical analysis that we did for this project. Mean age of patients was 64 years. Most patients were men, and 60% had prior PCI. The most common target vessel was right coronary artery, followed by the left anterior descending artery. Technical success was 87%, procedural success was 85%. The incidence of in-hospital MACE was 2.1%, and that of perforation was 5.1%. In the first table here, we can have a look at the baseline clinical characteristics of the study patients in both groups, perforation group and the non-perforation group. Patients in the perforation group were older, had higher prevalence of hypertension, and were more likely to have had prior MI, prior PCI, and prior CABG. Left ventricular ejection fraction was similar in both groups. In the second table here, we can see the angiographic characteristics of the study lesions. Right coronary artery was the most common target vessel in both groups. CTO lesions in the perforation group were longer. The proximal cap was more often ambiguous and were more severely calcified compared with the lesions that didn't result to perforation. While antegrade wiring was the most common successful crossing strategy in the non-perforation group, the retrograde approach was the most common successful crossing strategy in the perforation group. Although 34 of the patients in the perforation group of the lesions and the procedures there weren't technically successful. Procedure time, fluoroscopy time, radiation dose, and contrast volume were significantly higher in the perforation group. Technical success and procedural success were significantly lower in the perforation group, 66% and 55% respectively. The in-hospital MACE was overall 2.1% and was significantly higher in the perforation group, almost 18%. Mortality rate, periprocedural MI, emergency CABG, repeat PCI, and pericardiocentesis were all significantly higher in the perforation group. In this first figure, we can see that the higher the open clean perforation score, the higher the incidence of perforation in our study. More than 7% of patients with a score of 5 had a perforation, rising to almost 20% of patients with a score of 7. In the second figure here, we can see the probability of perforation stratified by the open clean score. And the higher the open clean score, the higher the probability of perforation. And the estimated increase in the risk of perforation with one score unit increase was 36%. The C-statistic was 0.62. The main finding of our study was that the open clean perforation score was positively associated with the risk of perforation during CTO PCI in an independent cohort of patients. However, the estimated statistic of 0.62 was lower than the 0.75 that Hirai et al. Reported in the original manuscript. So, given the association with the risk of perforation observed in this study and the ease of calculation, the open clean score may be useful for quantifying the risk-benefit ratio for each individual patient. Our study has limitations. It is an observational study without adjudication of clinical events by an independent committee. Quantitative coronary angiographic analysis were not performed, and procedures are performed at dedicated high-volume CTO centers, limiting the generalizability of the findings to centers with less CTO PCI experience. In conclusion, the open clean CTO perforation score is a valuable tool for estimating the risk of perforation during CTO PCI and can be useful for quantifying the risk-benefit ratio for each individual patient. This is the moderated poster that I will present next weekend at ACC. And I want to thank very much Larissa and Bryn for the statistical support and help in this project. Also, I'm delighted to inform you that PROGRESS-CTO has been accepted as a late-breaking science for the upcoming SKY conference in May. So thank you very much for your attention, and I'll be happy to answer any further questions.
fantastic. Do you have any sense, and it may not relate to your exact presentation, of where in the process of the procedure was the perforation? In other words, if it's such a difficult procedure, it takes me a really long time, it's more likely I'm going to create the problem. But if the problem itself is so difficult initially, I might just cause the problem. In other words, how much is really the score and how much is problems that I had with the procedure and the score is sort of associated, but not clearly?
Thank you very much for the question. That's an excellent point. So actually, as I mentioned in the perforation group, all the lesions were heavily calcified or the procedure was complex. So that was an issue. But I'm not sure that we know exactly the point that the perforation happened. So I hope
Because if I keep failing, I'll then go retrograde, and that might be good.
Yeah, I mean, the way to find this would be to know the time of perforation. Unfortunately, we don't have that. I think that would be the way to go. But most of those cases, I agree with you. They happen once you've done a lot of things, and then you start getting a little more aggressive or desperate, and things go south.
Yeah.
Thank you very much.
Okay, well, Dr. Saxena is another person that decided to go on holiday to pick up a cold, but she's here today, and I will not read the long bio that you did not write that brings us back to Brookings, South Dakota, but we did recently get to hear from her about the cardio pregnancy program here that she is central to, and of course, we know that her interests are in women's and heart disease, cardio obstetrics, prevention, non-invasive imaging, as well as cardiac critical care. So she is the first female governor of the Minnesota chapter of the ACC, and she's going to talk about Takotsubo syndrome. Thank you.
Can you hear me now? Okay. So I apologize if I start coughing. I did go to Hawaii and bring back a cold. So we have a poster at ACC on Sunday, for those of you who are there, looking at stress myocardial blood flow, which is abnormal during acute Takotsubo syndrome. This is the poster that'll be presented. I have no disclosures. Coronary microvascular dysfunction is a proposed mechanism for Takotsubo syndrome. To date, it is unknown whether changes in stress myocardial blood flow exist during acute Takotsubo. Associated mechanisms, and of course, the natural course of such abnormalities. So what we did was a proof of concept mechanistic study, cardiac magnetic resonance imaging with T2 mapping and quantitative stress perfusion were used to comprehensively evaluate acute Takotsubos. And 6 months later, my hypothesis was that these women had coronary microvessel dysfunction to begin with. And then something happened that led to the acute Takotsubos. Between March and September of 2021, patients who met criteria for acute Takotsubos with mid-apical regional wall motion abnormalities, no significant coronary artery disease were approached. After informed consent, patient underwent comprehensive adenosine stress CMR with cine imaging, T2 mapping, quantitative perfusion with automated inline quantification of both global and regional myocardial blood flow, in addition to late gadolinium enhancement imaging. The same protocol was then repeated 6 months after the initial exam to assess for interval changes. We had 4 patients so far. We've had more, but this is what's presented at the poster. Women, of course, all of them, age range between 49 and 77 years with emotional trigger and mild troponin elevation, which I'll go over in a minute. CMR was performed within 3 days from presentation. The LVEF was about 30 to 45% with regional myocardial edema and hypokinesis or akinesis of the mid and apical segments. LGE was absent in all of our patients. In the acute setting, global myocardial blood flow at rest was normal, and global stress myocardial blood flow was actually normal, but apical stress myocardial blood flow was abnormal, and there was a base to apex ratio, which was greater than 1.5. At repeat 6 months, and this is what is quite astounding to me, we've had 3 out of the 4 patients come back so far. There was absolutely a resolution, of course, of the myocardial edema, but there was absolutely a normalization of stress myocardial blood flow as well. And so there was no evidence of ongoing microvessel dysfunction. So, of course, all women, as you can see, age about 49 to 77. Peak troponin, we had one patient whose troponin peaked at 11. It was kind of all over the map. All of them were apical ballooning, ejection fraction as low as 30%, and all of them had emotional triggers. As you can see here, the acute rest global myocardial blood flow was normal, and the acute stress myocardial blood flow was normal. But when we looked at the basal to apex ratio, this was abnormal acutely and then normalized. Here's the T2 mapping, and as you can see, of course, it's abnormal in the apical areas consistent with myocardial edema, and they had apical ballooning, which of course resolved at 6 months. This is the plots that were demonstrated by the inline quantitative software, and as you can see, the apical segments are definitely much lower than the basal segments, and at rest, they're normal. What's really impressive, and again, we have this now in 3 patients, is that the 6-month post-recovery, there is no evidence of diminished myocardial blood flow, no evidence of an abnormality in their myocardial perfusion reserve. And so really, they have completely normal myocardium 6 months later. During the acute Takotsubo's, rest myocardial blood flow is normal in all segments despite the abnormal contraction, and the regional myocardial blood flow response to adenosine stress is decreased in abnormally contracting segments, and the acute global myocardial perfusion reserve is also reduced. The abnormal response may actually reflect intrinsic acute microvessel dysfunction. More than likely, it's the consequence of the regional myocardial edema, as we do not see any evidence of chronic microvessel dysfunction lasting later. Acute findings are rather transient and may just be circumstantial. These findings have resolved at 6 months, along with normalization of the myocardial edema and myocardial contractility. And this really unique thing that we're able to do here at MHI with automated quantification of myocardial blood flow may offer insights into the mechanism of Takotsubo's. So did not uphold my hypothesis. Thank you.
Great talk, Retu. I'm curious, how much edema do these hearts get compared to, say, like a STEMI with reperfusion? Because I'm just wondering if maybe, is this a variant of ischemia reperfusion injury?
We haven't looked at that, but we will now. In comparative,
It's generally more.
Yeah.
So what happens with microvascular obstruction, you take out signal, so you'll see less edema within the area of involvement.
Okay.
And then you can find very large areas of edema. All the areas of wall motion abnormality have edema, generally with stress cardiomyopathy.
Because like, going back to pigs again, but if you tie off a pig artery, you get no edema, but if you reperfuse it, you get
The myocardium,
you get
yep.
huge amounts of
Reperfusion.
edema. So, I mean, there's clearly edema as part of the ischemia
Well,
reperfusion
and-
injury.
And I think way back when there was some thought that this was like a missed myocardial or a recanalized vessel, right? Way back when we first started recognizing that that was also a hypothesis, which has been proven untrue because these vessels do not look like they've been recanalized. I still think that what we're going to end up learning is that this is truly injury due to the overwhelming catecholamine surge. But as John pointed out, more so than in the reperfusion injury.
Right. It could cause microvascular spasm, and then, and then there's your IR injury or whatever.
Great presentation. Actually, today, with the new supersaturated oxygen we now have, the giving high PO2 might be a good one. I mean, I know it's not the indication for this, but given this is all a perfusion injury, right? Maybe that's a good study to do, or just.
They do recover, at least. You're talking about with Takotsubo?
That's right.
Oh,
I think it's a good recover anyway. So
At 6 months, I mean, what was astounding to me, my hypothesis was that these women had some degree of chronic microvessel dysfunction to begin with, that then led to an emotional stressor that led to the injury, right? They have completely looking normal microvessels 6 months later. I mean, it's astounding, the maps. They look completely normal.
Don't you think there's so much more of this now than there was 20 years ago?
Yeah, but I mean, I think that's just,
I
there's
mean,
so
I know
much more
obviously we have better
anxiety.
tools and everything, but.
There's so much more anxiety and
everywhere.
stress and, you know, COVID has
Right,
helped
did
so
COVID
much.
cause Takatsubos to go up? Or?
We haven't looked, but we should.
Probably did.
We should. I wonder if that's the case.
You didn't find any in your
Study?
study, Takotsubo?
We did not, actually. But that was just a small proportion, you know, the
Yeah.
cardiovascular.
Because you
ones,
just looked
but-
at the deaths, right?
Right.
Thank you.
Okay, last but not least, Dr. Miho Fukui is an international research scholar at the Cardiovascular Imaging Research Center and Core Lab, and she completed her cardiology fellowship and PhD program in Japan, and then went to the University of Pittsburgh Medical Center in 2017 and worked with Dr. João Cavalcante. And so she followed him in September of 2018, so she's been here for quite a while. And she's a lead analyst of our core lab and prolific researcher, so welcome.
Thank you for this opportunity to our study about deformation of self-expanding TAVR prosthesis for heart. I'm going to present this study at ACC as a moderate poster. So, heart hypo-attenuating leaflet at thickening is a finding on CT that may occur from TAVR and may affect the prosthesis valve function and durability, as well as increase the risk of thrombosis. But the mechanistic insight into causative factors for heart in TAVR prosthesis remains limited. So this study aimed to determine the relation between prosthesis deformity in self-expanding TAVR valves and the occurrence of heart. Using 30 days post-procedure CT in 213 patients who received TAVR, we comprehensively assessed the structure of implanted evolute valve, especially focusing on the three important factors representing TAVR deformation. The first one is eccentricity, that's measured by minor and major diameter of the area at each of 6 levels, as shown here: phlegm outflow, leaflet outflow, prosthesis waste, leaflet inflow, native annulus, and phlegm inflow. The number of eccentricity of the circle close to 0, while that of oval shape close to 1. The second one is asymmetric leaflet expansion, as you can see here at the coaptation level, which is evaluated by the degree of the expansion of each prosthesis leaflet. Greater degree represent more asymmetric leaflet expansion. The third one is neosinus volume, which, as you can see here as red, is the volume of the prosthesis leaflet within the frame. Let me show you our result. Overall, heart occurs in 16% in the entire cohort. Patients with heart had less use of anticoagulant therapy than those without heart. Otherwise, there was no difference in baseline clinical, echo, and TAVR procedure characteristics. Eccentric expansion was common in evolute valve, especially at the inflow side, but patients with heart had greater degree of eccentricity, which means more oval shape, especially at the prosthesis waist, leaflet inflow, and native annulus level. Using ROC analysis, we also confirmed that the level of leaflet inflow, which corresponding to the nadir of the leaflet prosthesis leaflet, was the strongest predictor among the 6 levels. Patients with HUD had also had greater degree of asymmetric leaflet expansion and smaller neosinus volume than those without HUD. Aortic valve morphology, calcium score by pre-procedure CT, implant depth, counting, commission alignment, stroke volume by post-procedure CT were also measured, but no difference in these CT variables between the two groups. In a multivariable regression analysis, all the 3 factors of TAVR deformation remain associated with the heart occurrence along with the use of anticoagulant therapy. Here's the example with and without HUD. You can see here greater degree of eccentric expansion and greater degree of asymmetric leaflet expansion and eccentricity than case without HUD. As you can see here, eccentricity at leaflet inflow, asymmetric leaflet expansion, and neosinus volume was directly related with the heart occurrence across all valve sizes. Patients with HUD, which is orange, had greater degree of eccentricity, which means a more oval shape, and greater degree of asymmetric leaflet expansion and smaller neosinus volume. Furthermore, the greater degree of eccentricity was associated with a smaller neosinus volume. Importantly, there was no heart case in less degree of eccentricity with larger neosinus volume, which means heart did not occur in valves that's fully expanding in a regular circle. In conclusion, TAVR process deformation, eccentricity, asymmetric leaflet expansion, neosinus volume might explain heart occurrence following self-expanding TAVR prosthesis. This data may have implications for both design and deployment technique to improve clinical outcome with TAVR. Thank you for your attention.